How's that? Great. Thank you. Good morning. I'm very pleased to welcome you to this official press conference about the future of HIV funding. I'm Dr. Jen Cates. I'm the Vice President and Director of Global Health and HIV Policy at the Kaiser Family Foundation based in Washington, D.C. I would like to add a special welcome to those of you who are joining us online. The session is being live streamed on the AIDS2018 website, and a recording will also be posted there. In a moment, we'll hear brief remarks from our panelists, then we'll be glad to take your questions. 3 of the panelists will be sharing study results, and the embargo is now lifted for all of those studies. Before I turn to them, and to help set the stage a little bit for our discussion this morning, I want to share some of the main takeaways from a report that we just released, the Kaiser Family Foundation with UNAIDS, looking at the latest trends in donor government funding for HIV. We've been tracking donor government funding for HIV for more than 15 years with UNAIDS. We began at a time when there was very little funding available, and we've been able to document a dramatic scale-up as new programs were launched, PEPFAR in particular, and the Global Fund, and investments by donors that really changed the trajectory of the epidemic. And while today we know from data that UNAIDS has, donors represent not the majority of funding in all low and middle income countries, but in many countries they are the far greatest share. However, we're in a very different age of financing today. Our latest report finds that there were no new significant commitments to HIV from donor governments in 2017. While we found that disbursements, which is funding spent, from donor governments rose after 2 years of declines, this was largely due to a shift in the timing of US disbursements from PEPFAR, as funding committed in prior years was spent in 2017. This was not new funding. Funding has been flat for several years. Next year, therefore, it's expected to return to lower levels. And even with this 1-year increase by the US, which was just due to a spending timing, funding has still not returned to its peak from donor governments, which was in 2014. In fact, the majority of donor governments decreased their spending on HIV in 2017. So without new commitments from donors, it is expected that funding will decline again. What does this mean? According to the latest UNAIDS report, Miles to Go, there remains a funding gap of close to $6 billion between what is estimated to be needed to reach fast-track goals and where we are. And I think importantly, as they point out, even a relatively short delay will lead to millions more new HIV infections and deaths. Given the size of the gap, it is not clear how it will be made up, especially in the near term. And obviously, spending what we do have as efficiently and effectively and targeted as possible is essential. So this is the backdrop for today's session. And with that, I'm going to turn to our speakers. Our first speaker is Deepak Mathur of UNAIDS. He will share the results of a study that looked at determinants and aggregate estimates of HIV domestic public spending in low and middle income countries from 2006 to 2016. Deepak, please go ahead.
Good morning. I'm pleased to be here on behalf of UNAIDS to talk to you about the investments made by governments on HIV in low and middle income countries. In 2017, domestic resources accounted for 56% of all HIV resources available in low and middle income countries. The total resource availability rose to $20.6 billion, which was an 8% increase compared to 2016. Much of this increase in 2017 can be attributed to continuing increases in government spending and increases from international resources. However, as we have heard, increase in international resources was due to unused resources in pipeline, but not due to new commitments. Between 2006 and 2017, there was a 3-fold increase in domestic public spending on HIV. Most of the increases came from upper middle income countries, which contributed to 85% of domestic public spending in all low and middle income countries. There was a growth in low income countries as well. There was a 3-fold growth between the same period, 2006 to 2017. However, their contribution to total HIV spending from governments in low and middle income countries was just 4%. At 47%, Eastern and Southern Africa has the highest share of domestic public spending in all low and middle income countries, which is followed by Latin America and the Asia Pacific. Despite a high share, there was still about 60% dependency on external sources in East and Southern Africa. It was even higher in West and Central Africa, which was 70% dependency on external sources. Domestic spending per capita varies significantly between different income groups. In East and Southern Africa, across the whole population, an USD 10.4 was spent on HIV from domestic public sources, whereas in West and Central Africa, it was just $0.4. And in the Middle East, it was 0.2 USD per person. In upper middle income countries, we found that domestic public spending on HIV was $8, while in low income countries, it was just 0.36 US dollars per capita. The data show that we are almost 20% short of the annual resource needs for HIV to achieve the 2020 targets set by the UN member states. Filling this gap is urgent, and time is running out. The gap in funding will have to be mobilized from all available funding sources. We urge on donors and governments to step up funding in AIDS response so that we have a fully funded AIDS response. And not fully funding the AIDS response will have drastic impacts. If targets are missed by 5 years, an additional 2.1 million new infections and 1 more million people will die of AIDS-related illnesses. Thank you.
Thank you, Deepak. Our next speaker is Annie Hagenstad of the Harvard T.H. Chan School of Public Health. She will discuss the results of a study looking at trends in HIV spending by financing source and spending category in 188 countries from 2000 to 2015. Annie?
Thanks, Jen. I'll be talking about a paper that we published in The Lancet in April 2018. We've been estimating development assistance for HIV for 9 years, but in our most recent piece in The Lancet, we for the first time estimated government out-of-pocket and prepaid private spending for 188 countries. Similar to what Jen and Deepak have emphasized, we found that development assistance for HIV has not grown as much in recent years as it has in the past, but government health expenditure has continued to increase despite this lack of growth. We also find that out-of-pocket payments made at the point of care that can potentially put people at risk for catastrophic and impoverishing expenditure are 2/3 lower as a share of total health expenditure for HIV as relative to all health spend. So that's to say that governments and donors make up the bulk of spending on HIV. We compare spending across World Bank income groups to the burden of disease, notably disability-adjusted life years. There we find that 30% of all HIV spending takes place in high-income countries, where less than 2% of the burden of disease takes place. In low-income countries, where 30% of the burden of disease occurs, just 16% of HIV spending takes place. Finally, our piece also highlights the vulnerability of many high-burden, low-income countries to potential future declines in development assistance for HIV. In South Asia, we find that 45% of HIV spending comes from development assistance for HIV. However, or furthermore, in sub-Saharan Africa, 65% of all HIV spending comes from development assistance for health. This is particularly concerning in the 26 countries in which 80% of all spending comes from development assistance for HIV, and is particularly notable in some of the PEPFAR priority countries where a substantial amount of HIV spending comes from development assistance. So I think that's all from me. Thanks, Jen.
Great, thank you very much, Annie. Our next speaker is John Stover of Avenir Health, which is based in Connecticut in the US. His study examined ways to optimize global investments in HIV, which obviously is an important area of research given what we're all talking about. It's critical to make the best possible use of resources we have, especially at a time when donors are, at best, not increasing investments and maybe scaling back. John, please go ahead.
Thank you, Jen. Yeah, I'm going to change gears a little bit and talk about how we use the money that is mobilized for HIV programs. And for those of you who've looked at the recent UNAIDS report, you've seen that global spending on HIV is $18 to $20 billion, and it's been fairly constant over the last several years. Yet at the same time, we've seen real progress, particularly measured progress in terms of number of people on treatment and expansion of programs to provide voluntary medical male circumcision. So how have we achieved this progress with level funds? We've done it by improving the efficiency with which we deliver programs. So we wanted to look at what are the options for continuing to have improvements in efficiency. And we're measuring that in two ways. One is technical efficiency or implementation efficiency, which is how much does it cost us to provide a service, to reach a sex worker with information and services, to conduct a male circumcision or to distribute a condom. And then the second one is allocative efficiency. Are we allocating the funds to those areas where they will be most efficiently used? So when we look at technical efficiency, we collected information about the unit costs of providing a service, reaching a person, providing a service across about 50 countries around the world. And when we look at that information, there's several things that jump out at you. One is that there's a huge variation, even in the same service, delivering a condom or putting one person on treatment. You can see a range from a couple $100s to $7,000 or $8,000 to treat one person. Now, clearly there are some variation that we expect based on income levels in countries and whether facilities are urban or rural, et cetera, but that only explains a small part of the variation. So while we see lots of programs that are very effective, we can also see lots of opportunities for looking at interventions that are much more expensive than others of the same type, and trying to understand why, whether it's simply because they're reaching harder to reach populations or higher quality, or it's because they're missing opportunities to deliver the service more effectively. Second, then, to look at allocative efficiency, we used a mathematical simulation model called GOALS, which we applied to 52 Global Fund eligible countries. We focused on Global Fund eligible because then these are countries that are receiving a significant amount of international assistance as well as their own domestic resources. So we set the model up for each one of these 52 countries, and then we ran simulations where we scaled up each intervention one at a time in order to calculate the cost effectiveness, and I'm going to focus on cost per infection averted, of each intervention, each of 13 interventions in each of the 52 countries. So we give a big table of how cost effective each intervention is in each location. And then we can look at that and see what does it tell us about whether funds are going to the right places and being used for the most cost effective interventions. And several things jump out when you look at that information. One, again, is the huge variation that we see across countries and interventions. Some of it is explained by variation in unit costs. Some of it is explained by variations in the epidemic itself. And some is, frankly, quite hard to explain. One thing we see is that 17% of these combinations of interventions and locations are cost savings, meaning if you take the long view to 2030, the money that we put into, let's say, a medical male circumcision program today is going to be more than offset by savings from not having to treat those people that don't become infected in the future. So 17% of these interventions are cost savings when you take the long-term view. So the most cost-effective, all interventions were found to be cost-effective somewhere. But the ones that were cost-effective in most locations are condoms, outreach to sex workers, voluntary medical male circumcision, and also opioid substitution therapy in many cases. These interventions together account for only about 15% of total spending, but they're the most cost-effective. However, they're only implemented at about 70% of need. So clearly, right off the bat, we can see that there's opportunities for efficiency gains by making sure that these most cost-effective interventions are fully scaled up. We do see that the most cost-effective interventions, by and large, are in Eastern and Southern Africa because incidence is highest and costs are relatively low. Most of the global resources are focused in this region, so that's an indication of good allocation. And then finally, so I mentioned earlier that in the UNAIDS report, it says that we're spending $18 to $20 billion, but we know that the need is $26 billion. And I don't want you to go away thinking that, okay, by improving our efficiency, we don't need the $26 billion, because that $26 billion estimate actually assumed that we would continue to achieve these efficiencies in implementation. So there still is a gap that exists, and in order to achieve our goals, we both need to fill that gap in resources required, but also to continue to make strides in improving cost effectiveness of the way we use those funds. Thank you.
Thanks very much, John. Just to point out that the $6 billion gap approximately is the entire amount that the U.S. government commits each year through its bilateral and global fund programs. So to fill that gap, it would be essentially say the U.S. would have to double what it's doing, which we know is not a possibility. So just to give you a sense of the size of that gap. Now that you've heard from a lot of the data, we think it's really important to hear about the role of advocacy and effective advocacy in this environment. So I'd like to bring in the voice of a leading activist in HIV, Maureen Malanga of HealthGap. Maureen is a senior campaigner for HealthGap in Kenya. She has been a leader on a number of important HIV advocacy issues, including access to treatment. Maureen, please go ahead.
Thank you very much for giving me the opportunity. The world has just 2 years before the deadline to achieve the goal of fast-track targets, stemming the HIV tide by 2020. But the global AIDS response is off track. Progress has stalled or is reversing. Why is this happening? Donors are breaking their funding promises. As a result, life-saving treatment and prevention services are not reaching people in urgent need. And this must change. The clearest indicator of this new crisis is mortality. Progress has stalled. Nearly 1 million people still die of AIDS-related causes each year. According to the fast-track goals, being on track would mean bringing deaths down to 769,000 in 2017. Instead, 940,000 died. This is a massive failure. New infections are not falling fast enough. HIV prevention services are not being provided on an adequate scale and are not reaching people who need them the most. This is being seen on the ground. In Homa Bay, Kenya, MSF showed that almost half of the HIV-positive patients who were admitted to hospital died, many of whom had been on treatment, but who either were not supported to stay on treatment or whose treatment was no longer working. One of the major problems is the pace of scale-up. At least 2.3 million people were added to treatment. That's about the same number as the year before, at a time when we have to be moving faster and not flatlining. Funding has been flat or declining, holding back the pace of scale-up. 8.1 billion was dispersed by donors to fight HIV last year. But if we look just 3 years before, 13 out of 16 donors cut their funding. PEPFAR has been the far biggest donor, PEPFAR has been the biggest donor by far in East and Southern Africa and has been scaling up even after flat funding. But scale-up is reaching an end. Programs have no more efficiency gains to leverage. PEPFAR is simply running out of money to take programs to scale. Here are just a few examples. The DREAMS program to prevent HIV prevention among adolescents and young women has shown remarkable results, cutting new diagnoses and empowering young women. But it reaches a tiny fraction of those in need. In Kenya, for example, there are 7.2 million women and girls between the ages of 10 and 24. The DREAMS goal is to reach over 400,000. Just 6% of these women. At this scale, we will never halt new infections. There are 70 districts in Kenya, but PEPFAR started in just 4 districts. This year, they are only adding 3 more districts. And next year, they won't add any more because there is no more funding. So in this room present right now, there are experts who would like to stand up and share examples from their countries about how flat funding is blocking life-saving treatment And I would like to start by calling on John from Tanzania to share his statement.
Hello, my name is John Kashiha, and I'm working with the LGBTI organization in Tanzania. I'm program director. For the case of Tanzania, in Tanzania, we need to get HIV self-testing, education, adherence support, and access to PrEP to 20,000 men who have sex with men, trans people, sex workers, and people who use drugs, who are experiencing the worst of the epidemic in upcountry urban regions with a HIV prevalence, where there is a huge hostility environment and security issues in regards to access to the health services. For this case, we are actually requesting to, all services will cost almost like a 400,000 USD. But you can tell us no money for this. That's how we know there is AIDS funding crisis. In this also, we will never end in the epidemic if we will not invest in the right place to the right people. Thank you.
I would like to call on Eric Micheka from Malawi as well.
Thank you very much, Maureen. My name is Eric Mcheka. I come from Malawi, the southern part of Africa. Yes, commenting on the issues regards funding. In Malawi, currently we have 750,000 people on ART. Out of these people, it takes 2 years before one gets viral load testing. However, with $15 million, it will enable the people have their viral load testing before Malawi transitions to TLD. And this is going to empower people to begin to demand their viral load every year. And not only that, it is even going to help Malawi have the epidemic under control as well. Apart from that, currently with regards to voluntary medical male circumcision, we are 23% coverage. However, with $13 million US, it will help Malawi have voluntary medical male circumcision covering 6 districts, and this is also going to help Malawi have the epidemic control because it is going to reduce the number of incidences. Thank you very much. And as I say, they tell us there is no money, and this is how we know that we have AIDS funding crisis at the moment, as Maureen has already alluded to. Thank you.
Oh, and last I would like to call Chamu.
In Zimbabwe, we are facing a funding crisis with a gap of about $48 million to reach at least 200,000 people. And statistics are also showing us that men are hard to reach in terms of getting services for HIV. And it only requires $10 million to at least reach about 250,000 men using community-based approaches. So we really requesting that we prioritize that, because failure to do that, it will result in quite a lot, this crisis will continue. So this is our plea to the external and internal funders. Thank you.
Thank you so much. And in conclusion, in the next 3 years, an additional 2.8 million people must be added each year, but there's no new commitments to increase resources. 7 years of flat funding from the US and reduction in contribution to the Global Fund by major donors will not get us to the end of the epidemic. It is the responsibility of political leaders, national governments, and the international community to make sufficient financial investments and establish the legal and policy environments needed to bring work of innovators to global scale. Thank you.
Thank you, Maureen, and to your colleagues as well. Thank you for sharing your perspectives. So finally, we thought it would be helpful to hear from a policymaker in a donor country. We're very pleased to have Baroness Liz Barker with us. She's been a member of the British House of Lords since 1999. She's been very active on LGBTQI rights, sexual and reproductive health issues, and HIV policy. Baroness Barker, please go ahead.
Good morning. Thank you very much indeed for inviting me to take part in this really important discussion. About 15 years ago, I was at a conference, and a long-established and very famous HIV physician was on a panel. And somebody said to him, asked him a question, and he said, "Don't you get tired? After all these years, are you not tired?" And he sat there and he said, no. And he said, apart from anything else, this virus, it mutates and it changes. And that makes it one of the more interesting medical challenges to work on. Hold that thought while we think about funding, mutation and changing. There is, at this conference, a lot of good news around. We know that from 2000 to 2015, there was a 20-fold increase in people born ARTs. We saw 50% reduction in deaths from HIV. We've got exciting innovations like PrEP coming along. But you're right, everybody in this panel is right. We're not on track to meet those ambitious targets of 90. But there are very, very good reasons to continue our investment. You, like me, probably go to a lot of meetings where our biggest challenge is to convey to the people in the room that AIDS isn't over. It really is not over. But we've got a lot that we can be hopeful about. The thing is, picking up on the points made by all of the panel members, we need not just to continue to invest, but we need to reorientate our investment in the fight against this virus. In our recent report from our all-parliamentary group, No One Left Behind, where we looked at the changes in funding, principally from DFID and through the Global Fund, in which I'm very pleased Maureen and I worked together. We didn't actually meet until yesterday, but we worked due to the wonders of Skype. We talked about what it was like to sit in London as a donor and to sit where she does on the front line. One of the major things that we concluded was that many donor governments, ours included, use GNI as a determinant in funding. And we came to the conclusion that that is far too crude. And one of the reasons why we arrived at that conclusion is because we know that by 2020, 70% of people with HIV will live in middle-income countries. And therefore, taking the gross national income of a country does not lead you into the more subtle analyses of the kinds that our colleagues here were talking about. And if we can't get our analyses right, then we can't get the responses right. The second thing that we concluded is that all governments, and particularly donor governments, have a responsibility to take down or help to remove those barriers for the key populations in the countries where prevalence is so high, the unpopular people. And I'm proud to say that the United Kingdom government has recently given a lead to that. We take our responsibility as a former colonial power extremely seriously. And therefore, on a non-party political partisan basis, I was very pleased to see our Prime Minister give a commitment at the recent Commonwealth Heads of Government Summit in the United Kingdom that the United Kingdom would work with all countries in the Commonwealth who wish to change their laws and that discriminate against LGBT people. Many of them do so because of the legacy of the penal code that they inherited from us as a colonial power. And therefore, whilst those countries are now quite rightly independent, we can't force them to change their laws. We can assist them, and a fund of £5 million has been set aside for that, and the UK government has also pledged that they will give as much technical assistance to countries who wish to do that. The message is very clear. In the United Kingdom, we long ago realised that those sorts of discriminatory policies are very, very expensive in terms of health and global economic output. If it was good enough for those of us in the first world to go through decriminalisation, then it should be for us to help others. The final two other things that I want to say. The major funders, and in particular the Global Fund, need to look strategically with governments, recipient governments and civil society about how one can develop sustainable plans for maintaining the good progress, and particularly for starting to refine some of the interventions along the lines that Dr. Stover was talking about. It's not just a matter of continuing to fund exactly what has been funded in the past. The last 30 years of work has been a massive investment. It is now time to sustain the level and quantum of funding and to think again in perhaps some very new and innovative ways about how we do that. But let's take home one message. If we do not work with all of those people in the front line of this epidemic, then all the funding in the world, in the main countries of the world in which we do have the majority of the funding and the innovation, we will not beat it, but we can if we put our minds to it. Mutate and change our funding patterns.
Thank you, and thanks to all of you on the panel. It's now time for your questions. If you do have a question, please come up to the mic, let us know who you are and what outlet you're from, and try to keep it a little short. Thanks.
Hello, I'm Jan Tuczynski from German Public Radio, and it's a question for Mr. Mature. You said that not fully funding would lead to 1 million new infections and 1 million deaths. Could you just precise that calculation? Thank you.
Thank you. I think it was said as 2.1 million more new infections and 1 million more AIDS deaths. This statement comes from the UNAIDS estimates, which we have worked with, I believe, John Stover. We can come back to you on this. I don't have those values right now.
Hi, Molly Walker, Mid-Page Today. I have a question for Dr. Cates. Sort of domestic-wise, do you know, with this current administration, have there been cuts to PEPFAR? And if there's any sort of plan to kind of globally make that up, and what would the effects be domestically and globally, you know, with the budget cuts that, you know, we assume are happening with in the U.S. toward this disease?
Thanks. Good question. As those of you who follow the news out of the United States, for the last 2 years, the current administration has proposed pretty significant cuts to PEPFAR of about $1 billion a year, including bilateral and global fund contributions. But our U.S. Congress, which actually does have to approve a budget, has rejected those cuts. So even though those cuts were proposed 2 years in a row, they were rejected by the Congress, and the Congress has funded PEPFAR at the same level and the Global Fund at the same level. That is expected to happen again this year. But I think it's important to pay attention to that. It is a big change in the prior administrations, Republican and Democrat. There has never been proposals to cut this program. The issues have been how much would it increase or would it stay flat? So these proposals are really a statement about the priorities. It's important to put them in the larger context. These are budget cuts that have been proposed to many, many programs, but they have not actually happened at this point. And the same in our domestic, for those who are interested in what's happening within the United States, there had been some proposed cuts to some domestic programs as well for HIV, but Congress has, again, kept those at basically the same levels. So it's something that I think a lot of advocates are watching, but they haven't materialized to actual cuts. The one other thing I will say is we've done some analysis of what the cuts of those magnitude would mean when they first were proposed, and we found that they would have a dramatic impact on people, the number of new infections, the number of AIDS deaths, the number of people who are reached with antiretrovirals. So they would have a significant impact on health outcomes. We're not just talking about dollars, it actually translates into people's lives. Thanks.
Kerry Cullinan from Healthy News South Africa. This is for anyone on the panel who wants to take it. We've heard a lot at the conference about the need to end HIV exceptionalism and for HIV treatment to be integrated in primary health care, and discussion about the end of basically a closing down of UNAIDS. What do people think about whether this could continue, whether if there isn't a UN, well, first of all, what do you think about the future of UNAIDS in the next couple of years? And secondly, if there isn't a UNAIDS, will we still be able to maintain the focus that we need on HIV? Thank you.
Thank you for that question. I think it's a very interesting question. But as we have seen, there's still a lot of gaps, not just in funding, but in many, many dimensions of AIDS response. And HIV is not just a biomedical problem, and it has to work well. I mean, there should be a lot of coordination between different partners involved in this response, not just from a health perspective, but from different social perspectives. So my opinion is that there's still a strong need for a global organization to help in these elements. Thank you.
Yeah, if I could just add to that, I think there's two different concepts at work here. One is, how do we organize the long-term sustainable response after we achieve our targets? So 2020 to 30 to 40 to all the way out to 2050. And the other is the short-term emergency. So definitely for the long-term sustainable response, we need to figure out how to do things differently. How do we generate enough funding, and how do we organize ourselves to maintain the response long-term? Because even 2030, where we hope to nearly eliminate new infections and AIDS deaths, there will still be people living with HIV that will need support and treatment. But counterpoint to that is our short-term needs. We're not yet achieving our 2020 targets. We need a significant push over the next few years to reach those. That requires a doubling down on the way we're doing things now and more funding. If we don't reach those targets, then the long-term sustainability becomes even harder because we will have more catch-up to do. So I think there's two things you need to keep in mind. One is organizing ourselves for long-term sustainability, but not forgetting the short-term push we need to make right now.
I want to actually echo that and borrow an analogy that I got from a family member who's a firefighter in the United States. And he said, when you're fighting a wildfire, water is a very scarce resource, and you have to really focus on putting out the main fire at hand to save the most lives. You still have to pay attention to the other fires that might be springing up, but your main focus has to be on that wildfire. And I think that's we're at that tension point where everyone's looking around and saying, in the longer term, we have to pay attention to all these other areas, but it's still keeping focus on that wildfire.
My name is Peter Philipp Schmidt from the German newspaper Frankfurter Allgemeine Zeitung. This is a question to John Stover. You said that $26 billion would be needed. What would that mean? That 90% of the people would get ARVs, or all of them, all 37 million? Could you define that a little bit?
So the 26 billion is our estimate required to achieve the fast-track targets. So in terms of treatment, that's the 90-90-90 targets by 2020. Which then increased to 95-95-95 by 2030. It also includes goals for all the other interventions, so 90% coverage of male circumcision in those countries where it's appropriate, coverage of key populations, et cetera. So that's the amount required to get back on track to achieve the fast-track targets. And interestingly, once we achieve that level, we need to sustain that level beyond 2020. Resources don't go up, needs don't go up, but also they don't go down very dramatically in the short term.
Other questions? I'm going to ask a question of our panelists, and then we'll see if any others come up. One of the questions that has been talked about, and I think maybe Annie can speak to this, as well as Deepak, is this issue of domestic government resources and the fiscal space for more to be provided. Can you talk a little bit more about that, and what is that realistically? There's a lot of attention to it, but what does that really mean? How do we put some parameters around that? Whichever one of you wants to go first.
You want to talk? Based on a study that we've done, we have assessed what would be the impact on domestic governments if they were to absorb the cuts in international spending. We've looked at cuts at 10% and 20% scenarios. When we've looked at this, a lot of low-income countries and some of the middle-income countries would have significant effect on these cuts. Essentially, some of these countries would end up spending almost 3 times their health spending just to absorb the cuts on HIV. So it is drastic for many of those low and middle income countries.
Yeah, just to echo what Deepak said, our results show that many of the countries with the highest burden in Southern Africa, Eastern Africa, get more than 80% of their funding from donors. And if we think about what it would mean to reduce some of the development assistance for HIV to these countries, you know, that would mean major increases in the resources needed from the government. And these are countries, very low-income countries, and where it's difficult to raise resources for a number of reasons. And so there'd be real questions about the ability for sufficient domestic resources to be mobilized to fill those gaps.
Thanks. Are there any other questions? Yeah.
Hi, my name is Adele Solkis. I'm from the Global Fund Observer. I am wondering, with the Global Fund's 6th replenishment coming up next year, what would be your main message, and this is for anyone on the panel, to help the Global Fund build its investment case in light of the rather sobering messages you've been giving?
Maureen, you're the activist on the panel, so give us the message.
I think my message would be that political leaders and donors can get back on track on the cost to defeat HIV/AIDS. We have seen that there's $50 million new funding that will become a reality for PEPFAR in 2019. We have seen the Dutch Ministry of Foreign Affairs pledge $10 million to increase. There's an increase for West and Central African countries. So it is possible to increase funding for the HIV response. And that is we as communities would like to see an increase in the AIDS response so that we are able to meet our targets for 2020.
If I could just add to that, we are working with Global Fund to apply our mathematical modeling to help with the replenishment. So they're asking us to use the modeling to run scenarios to determine how much funding is required to get us back on track to achieve the goals. What are the consequences of not getting that amount of funding? So they can use that in discussions, and then looking at how allocation of funding affects the achievement. And all of that then goes into the discussions with the donors about, you know, how much money could be provided to the Global Fund.
I think the message, I would do two messages. The first is the evidence is there from the last 20 years that the funding this funding works. It has results. There are other areas of international development funding where it is not so clear to see results. So that's the first thing I would say. And the second thing I would say is that were the Global Fund not to continue at least at its present level, and preferably with more funding, then all of the investment that has been made up until now will be diminished because so much has been done. And I think the third message to say is that some of your funding partners, but also people on the front line, are not asking for indefinite funding of what is done now. They do want to see change. They do want to see re-examinations of things, but clearly working towards that goal of sustainability within countries has got to be a key part of what the Global Fund continues to do.
Yes, so we are at time, and I'm going to take moderator's prerogative to add my other thoughts on that question. Two things. One is if you step back and look at how the HIV response is organized globally, from an international perspective, it's two things, PEPFAR and the Global Fund. That's really the HIV response. So those two things are the fundamental components. That's part of the message. And secondly, I think we all, from where I sit, we do numbers, we do estimates, we do financing projections, but really we're talking about people. So I think that's that's the fundamental message that I would share. And I think with that, we're going to have to end. And I'll just say, remember the people we're talking about. Thank you very much for being here. I know that myself and others will be available to talk with you if you still have questions. And as I mentioned, the embargo is lifted for the studies that were discussed. Thank you very much for joining us, and for those of you online. And I hope you get more out of the next 2 days of the conference. Thanks.